Talk about the absorbable mesh and ventral hernia repair. It's a not new subject, but with time it's increasing in attention, and most of the centers, especially the big or tertiary centers, are like to use such meshes and to introduce it in the system. So I'm going to start directly in comparing the mesh and primary switcher. Going back to the basic, we know by default now is having a mesh repair is better than switcher repair, and at least recurrence, 43% recurrence in switcher repair and 24% in mesh repair in one of the studies that was published in NEJM 2000. What is the most commonly used mesh? I'd like to remove these. I can see multiple screens in my screen, so I cannot see my screen. So I'll try to reduce it here. Okay. Anyway, I cannot see my screen properly, but it would be fine. What is the most commonly used mesh nowadays? It's permanent synthetic mesh, either polypropylene or polyester, because it's non-absorbable, very effective, and very cheap. So the other question always is, what is the most common or most significant complication after mesh implantation, which is infection? We always think about infection even before recurrence in choosing the mesh type. Can we salvage a permanent synthetic mesh? Yes. Sometimes we can, sometimes we cannot. In EPTFE, we cannot salvage it, and it's, I believe, it's not being used now by FDA. Polyester, they have high probability of removal. Polypropylene, sometimes we can salvage our mesh, depends on the situation of the patient. So even if we manage to salvage the mesh, at what cost? It's a delayed wound healing, negative pressure. We can see now most of the patients that they have infection and we want to salvage the mesh and salvage the abdominal wall, we go with a vac dressing. The other things that we go for it is multiple hospital admissions, loss of work time, and also quality of life. So we always need to find a solution for that. Salvage is not an option for multiple times. Sorry. There's a patient who presented 2 days ago who had a laparoscopic ventral hernia repair in a tertiary hospital. Referred to the hospital with this picture. Came to the emergency with mesh and collection. After opening the abdomen, we found the mesh with pus adheres to the colon, and you can see the fistula in the middle of the picture, the screen. We removed the mesh, and we removed also part of the transverse colon with the transverse collocostomy. And also we removed a huge amount of abdominal wall, so the patient would have like loss of domain. As you can see in the left side of the picture, the abdominal wall is thick. It might be inflammatory process chronically, and it might be a desmoid tumor. We're still waiting for the pathology, but it was closed primarily. We did not apply mesh because in case of the patient has desmoid tumor, the patient needs to go back for surgery. American Journal of Surgeons in 2017 published a study with predictors of mesh infection. They calculated more than 3,470 patients, and 66 patients had infection, which is 1.9%. Out of all those 66 cases, 48 of them had to remove the mesh. When they went back and see what is the risk factors for that, they found immunosuppressive patients, immunosuppressive drugs using, and urgent repair, like emergency, or surgical site infection. 3 factors were the most common cause of recurrence and of having infected mesh. The predictors for removing the mesh is onlay position and also onlay position. And also they found out that there is another reason when the patient hasn't had surgery. I'll remove this. Trying to do so. Okay. Can't see my screen, but I hope that you're seeing it. The relations between SSI and hernia occurrence. there is a direct relation between infection and recurrence, as you can see here. When they compared 100 patients who had hernia repair, 16 patients got surgical site infection. 19% of them, they got a recurrence, while in the 85 patients who had no surgical site infection, only 4% had recurrence. So the recurrence increased with the surgical site infection. It is critical to select the type of mesh according to the patient's status, risk of SSI, mesh, infection. We cannot use the same mesh for all patients, even when it's like direct or when it's like a clean surgery. Do all patients are having the same risk of mesh infection? Of course not. Some patients, they come with infected wound like this on the left side of the screen, who's having the colon going outside, protruding from the skin. Other patients, they have multiple surgeries, like this patient on the right side who had previous kidney transplant and previous laparotomies, liver resection, and testicular problems. So not all patients have the same risk of recurrence, as we mentioned. The site of the hernia, the site of the size of the hernia, and also the bulk of the muscle are affecting this. In the modified classification system by Ventral Hernia Working Group in 2012, they grade they classify the wounds by or hernias by 3 types: grade 1, 2, or 3. So when we have a patient who's having a hernia, we have to grade them in 3 categories. Each category has a specific number of surgical site infection. Having this risk of surgical site infection will give us a hint what kind of mesh that we have to use. In grade 1, it was 14%. The patient had low risk of complications, no history of wound infection. In grade 2, smokers, obesity, COPD, diabetes, history of wound infection. Grade 3, of course, is contaminated. They have the highest rate of infection. What should we use for this in patients with high risk? So recently, the only alternative option other than the permanent solution or permanent mesh is the biological mesh. Nowadays, we have multiple collagen-based products from multiple brands. Most of them are used by surgeons. It incorporate and remodel minimal foreign body is left behind. Here we have a systemic review of biological mesh. When we use biological graft for ventral hernia, we can see 23% recurrence rate in contaminated wounds and 2.9 in clean. Now for the newcomer, like almost less than 10 years, we have biosynthetic fully resorbable meshes. The new studies are coming, better designing, longer follow-up. We have 4 types of biosynthetic fully resorbable meshes: Vicryl, BioA, Tiger, and Phasix. 4 of them are claiming that they're the best, and 4 of them, they're claiming that they can manage any kind of hernias, or most, at least. When we compare the biosynthetic fully resorbable mesh to biological mesh, in this study that was published in Surgical Endoscopy 2016, they compared the Phasix, the P4HB, to the biological mesh. Before the surgery, the ball burst strength is higher in biological mesh. But after surgery, they found that the burst is stronger in P4HB. I will try not to talk about the brands in this meeting, because the idea is to talk about the type of meshes and factory rather than the trade names per se. So I'll try my best, but I might. Biosynthetic fully resorbable meshes, after implantation, they found stronger burst strength than biological mesh, better tolerance resistance to infection than biological mesh. So in clinical data, in this study, where they were talking about using P4HB meshes for 25 patients, they found the recurrence rate is 9%, if I remember well, because I cannot see the screen properly. And the hematoma was 8% and the seroma was 4%. Also here, initial experience with biological polymer. They found also the complication rate is less when you use the biosynthetic material that is absorbed rather than biological meshes. So when they use the synthetic meshes, the resolvable synthetic meshes, they have less complication, 20% to 45% in biological, and also they have 6% to 23% in biological. Other studies also talking about the same thing with 18 months follow-up. Here is the comparison between multiple multiple studies that use the same mesh, P4HP meshes, 18 months, 414 days, 36, and also 1 year. So when we compare, we found that in 1 year we have 9% recurrence. In 3 years we have 15% recurrence. The surgical site infection is more with, it is less in this study that has 36 months, but the other one is more. I believe it's 15, because again, I don't see the screen. In comparison, there are multiple studies showing superiority of some brands over the other brands, which is not our topic, but we want to show that what is a practice that we're doing. At least in the practice that we're doing is comparing, finding 3 grades of patients. In grade 1, we can use the synthetic materials easily. I don't prefer to use the resolvable or the biosynthetic meshes in grade 1 because the surgical site infection is less and there is no high risk of infection. In grade 2, where it's more comorbidities, more immunosuppressed patients, most of the patients, post-transplant patients, I like to use the biosynthetic meshes rather than the permanent synthetic. In grade 3, of course, we have to go with something that's going to be absorbed if we need, because sometimes we don't need to go for using the mesh. We have to try our best to deal with it primarily until this infection healed. When it's healed, we can go primarily again and do it in more realistic ways. This is the poster that I this year. Using polyresolvable mesh 3 years follow-up. Did almost more than 100 cases in the hospital. This is like 16 cases who completed 3 years of follow-up, started from late 2016 to February 2017. In this study, I did 16 patients, single center, single patient prospective study. Surgery were done between September 16 to February 2017. Follow-up for 3 years. 13 patients were male, 3 patients were female. Age mean was 51 and BMI mean was 31. One of the patients actually was obese with 50 BMI. I was trying not to do this patient, but he was a brother of my case manager, so I had to do it. The ASA is 1 patient has class 1 and 2 patients 8, 3, 7 of them. So 50% of them were class 2 and 43% were class 3. The size of the defect was, if I remember well, 10 plus 4 minus 2. AHS classification M2, M3, M4. Modified VHWG classification, all of them were class 2. 56% of the patients had diabetes. 56% also had obesity. 12% asthma, 12% post-liver transplant, which is 2 patients. 2 patients post-kidney transplant. 4 had liver disease with controlled ascites. 1 of them had uncontrolled after surgery. Post-operative procedure, 1 patient. Post-colectomy, 1 patient. Church-Strauss syndrome, 1 patient. In this syndrome, the patients have a difficulty or inflammation in the blood vessels that decrease the blood flow to the organs and tissues. 4 patients, of course, were in immunosuppressive treatment post-transplant. 3 C-section, 2 prior hernia repair for different reasons, and 10 patients, 62% had previous abdominal surgeries. 87% of the patient had anterior compound separation. 31% of them had onlay technique. 56% has underlay with phasic ST or onlay. PCS or TAR, posterior component separation with transverse abdominis release. 2 patients, 12% had this technique. Type of incision was used, standard abdominoplasty or midline incision according to the site and the age of the patient and the BMI. Sometimes we'll give the patient a complementary abdominoplasty with this reconstruction. The operative time was almost 3 hours. The surgical site occurrence or the complication post-op. Two patients had skin necrosis. One of them was my fault actually when he was um, refashioning the umbilicus. I was pushing to keep the umbilicus, although I consented the patient that I'm going to remove the umbilicus. But when I saw it intraoperatively, I was like saying it might help, but it didn't work. It has necrosed. One patient had hematoma, two patients got seroma. The hospital admission, hospital stay was 5.9 or 6 days. Post-op readmission, two patients for those patients who had necrosis. No mortality, two patients got recurrence. The first one was having portal hypertension with controlled ascites. After surgery, by 1 year, patient started to have ascites, and this improved, this weakened the abdominal wall and had smaller hernia until this date of this hernia might increase in size. The second patient was a BMI of 50 patient, post-kidney transplant on immunosuppressive medication. This is the patient that had skin necrosis. Luckily, I got pictured him for him. This is like the picture before the surgery, and the middle one is during the surgery. The umbilicus was like a skin tag, so it tagged to the small tissues, like very weak fascia. I managed to put the umbilicus between the muscles and finish the surgery, but like after 2 weeks, the patient came back with a skin necrosis. So in conclusion, the perfect mesh is not there yet. And multiple factors do affect our choice of mesh, including the cost. The cost is very important, especially in poor places or other hospitals that they do not have this luxury of mesh. For grade 2 and above, I personally prefer to use the absorbable, fully absorbable biosynthetic meshes because the results in the literatures are superior. Larger, well-designed, long follow-up studies are coming very soon. Thank you.